Hello, I'm Dr. Kevin Banks, a nuclear radiologist from the San Antonio Military Medical Center, and I'm going to be talking about imaging of movement disorders from a nuclear medicine perspective. I wish I did, but I do not have any financial disclosures to share with you. During this presentation, I'll review the common movement disorders and their mimics, going to discuss various means for diagnosing movement disorders and their limitations, and then we're going to also review I-123 IOFLUPANE, aka the DATSCAN, its techniques and interpretation, and then finally identify some of the imaging pitfalls associated with it that can be encountered and discuss ways to minimize their occurrences. So when talking movement disorders, we're mainly talking about the Parkinsonian syndromes. That is an umbrella term for several neurologic diseases that share one thing, and that's a deficiency of the striatal dopamine, and that is due to degeneration of the nigrostriatal pathway. Dopamine is a neurotransmitter, and it's central to motivation, reward, and is also essential to movement control, mood, sleep, and cognition. Most cases of Parkinsonian syndrome are the classic idiopathic Parkinson's disease, and it's estimated to comprise 3/4 of the cases. It's the one you see with onset at about 60 years of age, men more commonly afflicted than women. It is the second most common neurodegenerative disorder behind Alzheimer's disease. It increases in prevalence with age, like a lot of other neurodegenerative disorders, and it reaches about 3% prevalence once you reach the age of 80. Other disorders under the Parkinsonian syndrome are less common and include entities such as multisystem atrophy, of which there are a couple subtypes of that, but in this case, we're specifically talking about the putaminal or the Parkinsonian version of MSA, which makes up 80% of cases. And then we're also talking about progressive supranuclear palsy and cortical basilar degeneration. And finally, included in this Parkinsonian syndrome umbrella is diffuse Lewy body dementia, which, though technically not a movement disorder, it certainly shares the deficiency of striatal dopamine and does have some movement-related symptoms. Just as a side note, diffuse Lewy body dementia is the second most common dementia. While it's not the second most common neurodegenerative disorder, it is the second most common dementia, also following Alzheimer's. So this is what we're talking about when we speak of the nigrostriatal pathway. There are 4 main pathways in the brain for dopamine, and the nigrostriatal pathway is the one that makes up the majority. 80% of dopamine is taken up by the nigrostriatal pathway, and this controls voluntary movement. So you can see there in the red that the pathway originates down in the midbrain of the substantia nigra. And those neurons then project up to the striatum. There they synapse with the postsynaptic dopaminergic terminals. And this is the site that we're looking at when we're performing a dopamine transporter imaging, again, more commonly known as a DATSCAN. Looking closely up in the striatum, this is what's occurring. On the left are the terminals of the neurons that originate down in the substantia nigra of the midbrain and project up into the striatum of the basal ganglia, and there they synapse with the postsynaptic dopaminergic terminals. What happens is there's dopamine stored in vesicles of the presynaptic terminals, and when the appropriate signal is received, the dopamine is released into the synaptic cleft. From the synaptic cleft, the dopamine interacts with the D2 receptors on the postsynaptic dopaminergic terminal. That evokes a response, and then at that point, what you see is in time the dopamine transporter, also known by some as the dopamine active transporter, hence the term DAT comes from. It binds to and brings the dopamine back into the presynaptic terminal, and at that point it's either broken down or it goes back into storage in vesicles for further use. What we are taking advantage of when we're performing DAT imaging is the fact that other entities will bind to this transporter. As you can see here on the side of the DAT transmembrane protein, that is where I-123 IOFLUPANE binds. It actually was originally identified as a place for binding of cocaine, and in fact, IOFLUPANE is a very, very weak derivative of cocaine. How we use a DATSCAN is for the assessment of patients presenting with signs or symptoms of movement disorder. In the right column, you can see are the Parkinsonian syndromes comprised of, again, idiopathic Parkinson's disease, cortical basilar degeneration, multisystem atrophy, and progressive supranuclear palsy. With the DATSCAN, what we're trying to do is differentiate these entities from disorders that mimic them, and that is diseases such as essential tremor, drug-induced Parkinsonism, psychogenic Parkinsonism, dystonic tremor, and sometimes vascular Parkinsonism. Vascular Parkinsonism is listed in italics just because it can be a very heterogeneous disorder, has been described various ways in the literature, leading to some confusion about the topic. But for the most part, many experts agree that vascular Parkinsonism will present with a normal DATSCAN. As a side note, the questions that's often asked is how often is imaging needed to help diagnose these movement disorders? Some people would wonder, is a well-trained neurologist clinical exam adequate? Unfortunately, often is not. While many patients do present with the classic symptoms and respond as expected to treatment, people who have researched this have found that even in specialty movement disorder clinics, up to 25% of patients can either be under or overdiagnosed with one of these Parkinsonian syndromes. So there's definitely a robust role for imaging to help tease out these difficult cases and achieve an appropriate diagnosis. So, interpretation. The good thing, in my opinion, is that it's most commonly visually based, so you do not need to have a quantitative or semi-quantitative software package. Ideally, experts advise for the image assessment to be done without integration of the clinical information. You kind of want to read it cold. You do not want the clinical history to bias you. What you're looking to see is two symmetric shaped comma regions, and that is the uptake in the paired striata. It must be emphasized that in addition to having this comma shaped, you need to see uptake that is intense and distinct compared to the background activity. And this feature will come into play with difficult cases as you look for a decrease in intensity compared to background to help differentiate normal from abnormal. Again, the striae should appear symmetric, but understand that some mild asymmetry can occur in healthy individuals. When faced with that, on a case where one thinks they appreciate some mild asymmetry and may be finding it difficult to decide whether it is pathologic or within normal limits, in my opinion, it's very helpful to remember that by the time these patients present to their clinicians, that at least 50% of the dopaminergic synaptic loss has occurred, and many experts estimate that number to be actually much higher, 70 or even 80% synaptic loss. So given that, mild asymmetry is not going to be when a patient presents for imaging. They are going to have significant profound loss, and that is likely a big part of why visual interpretation is so successful. In addition to the issue of physiologic asymmetry, there is a decrease in binding that occurs with normal aging. It's been well studied. It's about 5 to 6% per decade. But again, it's helpful to note that because when looking at patients with Parkinson's disease, they have a much more profound and rapid loss that's on the order of 10 to 11% per year. So is not a significant confounding factor. So let's go through some cases. This will be a normal case that you would see at the view box. We have our axial slices. In our institution, we use a Siemens product, so it's recommended to use the warm metal color scheme shown here. Interpretation is done via the axial slices. We rarely look at the coronal or sagittal reformats, and some places don't even create those. Now, I want you to focus here on the lower left corner, and if you look at those images there, what you're seeing here is a nice case of normal uptake. This is intense comma-shaped uptake that isolates to striata, and you have low uptake in the background. The uptake is relatively symmetric, so this would be an excellent example of normal. This is what we're looking at if you compare it to an MRI. You can see here the striatum on the right, patient's left. It's comprised of both the caudate head here and the anterior and the posterior aspects of putamen. The uptake in these areas is what makes this comma shaped. What we can't see here is the associated internal capsule located here between the caudate and putamen, and that's because the resolution of SPECT imaging, so it's going to look like just one unified structure. Again, it's comprised of the caudate and the putamen. And this will come into play knowing that these two areas, because they get affected differently in different disorders. So again, what you're looking at for a normal case is symmetric comma-shaped regions of activity that's comprised of the caudate and putamen and should be relatively intense and distinct compared to the surrounding background. I'm going to keep emphasizing that because when you come across challenging cases, the one rule, that rule of intense uptake compared to background is something you'll see violated. So let's review a case of abnormal. Here you can see a difference between what we saw previously. On the patient's left side, you see a normal comma-shaped uptake corresponding to the striatum. But on the right side, you see a loss of that normal comma shape. What you have now is more of an oval or a round shaped, and this is usually the earliest abnormality seen. This is decreased uptake in the putamen. If this is a patient with idiopathic Parkinson's disease, this uptake is a very typical pattern of uptake, and it corresponds to the contralateral side of their presenting symptoms. So I admit that if I'm faced with an equivocal case of loss in the putamen, I sometimes will ask the patient about where their symptoms are. And if they're ipsilateral, I can usually feel confident that the asymmetry is within normal limits and not related to their disease. If it's contralateral, it's less helpful because I certainly don't want to overdiagnose disease. Here's a more advanced case. It's what's called a type 2 abnormality. Again, as you look close at the images, you can see that there's loss of the putamenal activity now on both sides, and you have two period or oval shapes. This is considered a type 2 abnormality. Notice here that there's also increased uptake in the surrounding background. Again, another feature that tells you there's been synaptic loss occurring. Now compare what you saw in the last image to this case, which is a very severe form of disease. You look here on the MRI and you see a striatum, but on the DAT images, you really cannot find anything that corresponds to that. There's a complete loss of uptake in the striatum, and this is considered a type 3 abnormality, where you have complete absence of uptake in both in the putamen and caudate nuclei bilateral. And again, I'll note there's abnormal increased surrounding background activity, markedly different than the first case of normal we showed earlier. So again, reviewing normal versus abnormal. Normal on the left, two relatively symmetric comma-shaped areas of intense uptake compared to background. And then here, as you can see on the right, you slowly start seeing the increasing uptake in the background as the striatal uptake decreases. The top one there is a type 1 pattern where you start to lose that comma-shaped appearance because of decreased activity in the putamen. And then on both sides with a type 2 pattern and eventually a complete loss of normal uptake, denoting a type 3 pattern. With Parkinson's disease, afflicted patients will typically present with symptoms on the contralateral limb from where they have their putamen loss. Then they will typically progress in a specific way. There will be loss of uptake in the opposite putamen before the caudate nuclei are affected. This is not true in some of the other Parkinsonian syndromes. So again, you have type 1, type 2, and type 3 patterns of abnormal uptake on a DATSCAN. Now the question comes up, if you encounter type 1, type 2, or type 3 in clinic, what form of Parkinsonian disease is present? Unfortunately, it can't be determined. If you were to take a large number of patients, you could likely identify one group as progressive supranuclear palsy versus another group as, say, corticobasilar degeneration or multisystem atrophy, but at the individual patient level, you cannot. It remains a differential diagnosis to include diffuse Lewy body dementia in the appropriate clinical setting. So what other things can come into play here to try to help tease out what we're dealing with? Quantification, which I'll talk more about later, unfortunately suffers from the same challenges as qualitative assessment. It cannot tease out whether one is dealing with one of the atypical Parkinsonian syndromes versus idiopathic Parkinson's disease. There is something known as D2 receptor imaging, where instead of imaging the presynaptic terminal, you assess the postsynaptic terminal. It's not yet FDA approved for use, but if you had that available in, say, a research role, it would help because idiopathic Parkinson's disease would have normal appearance on D2 receptor imaging, where the other disorders, such as corticobasilar degeneration and such, would have an abnormal appearance. Again, though, that's not yet available for clinical use. MRI, most of the things that you'll see there occur very late in the disorder. It has low sensitivity and there's a lot of inter-reader variability, so usually not helpful. FDG PET is likely usually not helpful for differentiation between these two entities. It does have some characteristic findings, say in diffuse Lewy body dementia. Certainly if you have occipital hypometabolism or the preserved FDG uptake in the posterior cingulate gyrus, you may suggest it. But usually you do not recommend a clinician obtain an FDG PET to help differentiate between these disorders. And unfortunately, amyloid PET likewise does not have a role. So what's next? Well, all is not lost. There's actually something that can be very helpful coming from the nuclear medicine arena. And while I am talking to you about neuroimaging and molecular imaging, this is not the brain. We are looking at the chest here in a patient undergoing an I-123 MIBG scan. And what we use this for is to assess adrenergic function. And some bright researchers have realized that some of the patients with Parkinsonian syndromes have a loss of adrenergic function and some do not, and we can use that to kind of differentiate. On the left, you see a case of normal uptake. You see cardiac uptake of MIBG in a healthy patient, whereas if you lose that cardiac uptake, that's abnormal. So the question is, of course, what does this tell us in this situation? If Cardiac uptake is normal. That would imply you're dealing with one of the atypical Parkinsonian syndromes, such as CBD, MSA, or PSP. And if it's abnormal, you're looking at either idiopathic Parkinson's disease or diffuse Lewy body dementia. So certainly this exam may be very helpful if you're trying to tease out, say, between Alzheimer's disease and dementia with Lewy bodies. Likewise, this can help tease out whether someone is suffering from idiopathic Parkinson's disease versus one of the less common variants that are listed on the bottom left. So let's cover some pitfalls, because obviously not everything is going to be as straightforward as the cases that have been shown so far. So in this case here, you see abnormal uptake. There seems to be just two period shapes or oval shapes here, with radiotracer only binding to the caudates. This would typically be considered a type 2 abnormal scan. So this certainly could be a patient, say, with idiopathic Parkinson's disease who has progressed to involve both putamen at this point. But this is just one slice, and obviously the exam includes more than that. As you come further down this patient's exam, you start seeing what looks like more comma-shaped, but it has this kind of atypical bilobed appearance. And if you're like me, you wonder what's going on here. The striata seem to be kind of narrowed at the waist, and we haven't described that pattern up to this point. And this is what has been described as the semicolon sign. This is when you have an instance of the caudate nuclei and the putamen being seen on separate slices. So how does this happen? Well, ideally, when the patient is being positioned for the scan, they are placed all the way up in the head holder. The external auditory meatus should be in line with the corner of your eye. That's perfect positioning, ideal. But in this situation, when you see the semicolon sign, the patient has usually slid forward in the scanner so that their head is now tilted. Their chin is down. You can see that the ideal perpendicular line between the corner of the eye and the external auditory canal has been lost. If you were to see this on MRI, this is what's going on. Here, there is proper head positioning, so the axial slices are going through both the caudate and the putamen on one slice of the DATSCAN. But as the patient slides forward, now these structures are off axis to each other, and it gives us this view that you see on the right. If you're not convinced, you can see what reprocessing will do in this same patient with the right image, the result of reformatting to achieve true axial image. You see restoration of the normal comma-shaped striatal uptake. Obviously, it is easiest to avoid the pitfall altogether by reminding the technologist to try and ensure proper head positioning. That said, while proper head positioning is ideal, it is more important that the patient is comfortable enough to stay still for the entirety of the exam. This image acquisition can take 30 to 40 minutes, and so that allows for ample time for patient motion to occur, and motion is much more difficult to identify and correct than if they're just simply tilted in the scanner but remain still. So again, if the patient, either due to neck pain or some other disorder, cannot be in the ideal position, we will allow them to be off axis, and again, we can address this with reprocessing or just with visual inspection. Here's another pitfall. This is a patient with a very atypical appearance. The right striatum looks nice and intense, markedly distinct compared to background, but also markedly asymmetric compared to left. There's near complete absence of uptake in the left striata. It's important to notice here that background activity is very low, so this combination is discordant and unusual for a pathologic state. Like other patients, you go further down, and now you notice that the left striatum has a normal, healthy look to it. What's going on here is similar to the patient who slid forward in the headrest. This patient has their head angled laterally in the scanner, and you can get this appearance where you find the two striatum on separate slices. So if you're looking at them, it can be difficult to see that there is indeed symmetry. However, if you splice the images together, you'll see that indeed you do have these two comma shapes with intense uptake compared to background. There's that mild amount of asymmetry we've talked about, but it's not enough to be considered pathologic. Just like with the last patient, you want to ensure proper head position if possible. If not, and you encounter this in clinic, again, you can reformat it into a true axial plane, or simply just scroll through the images and assess each of the striata individually, as well as how the striata look in comparison to background. Look at your left, look at your right separately, and ensure that both have that nice, intense comma-shaped configuration. If so, then you can feel confident that you're dealing with a normal exam and not some sort of pathology. So here's another pitfall. You see this? Well, we're down to just two diminutive period shapes here in the caudate. You wonder if this is a very advanced stage of disease, but again, I emphasize the more and more you look at these, you realize the value you get from looking at the background and looking at the uptake in the background. You see in this instance that there's not significant increase in background activity. It's very, very low. So this kind of discordant image here, it's unclear what's going on. Compare this to a patient on the right I showed earlier with a type 3 scan where there's intense increase in background activity. So again, what's going on with this patient? Well, if you look at the coronal SPECT on this patient, which is displayed on the right of the screen, what can happen sometimes is that the field of view is large enough, and it includes the parotid glands, denoted there by the red arrows. The normal, more intense physiologic uptake in the parotid glands can cause a problem if it's included in the post-processing. It causes a scaling artifact such that the striatal uptake appears much less than it actually is. Now, if you look at this patient after exclusion of the parotids, it is indeed a type 2 scan. It's still abnormal, but now you can feel much more reassured by the increased background activity as one would expect. So interfering medications. Patient preparation, like for much of nuclear medicine, is very key. It begins as soon as the patient's scheduled for their appointment. At that point, you want to review their medications instead of making a mistake and waiting until they arrive at the clinic for the exam and have already taken possible contraindicated medications. What you want to do here is ask about anything that binds to dopamine transporters or causes mobilization of dopamine that could impact the quality of the scan. So, like in other scenarios, you want to try to discontinue those interfering medications for 5 half-lives if possible. And if we do encounter that scenario, and it's not frequent, we do refer them back to their provider to have the discussion of whether it's safe for them to come off the medication for the necessary length of time prior to the study. And sometimes it isn't, and that does not, fortunately, that does not always equate to a non-diagnostic study. The good news is that there are a lot of medications these patients tend to be on that do not interfere with the DATSCAN. These medications are commonly used to treat patients with Parkinsonian syndromes or other forms of dementia and things of that nature. Levodopa, carbidopa, the dopamine agonists, the neuroleptics, the cholinesterase inhibitors, all of these are okay to continue while undergoing the exam. They will not significantly impact uptake and interpretation. As a side note, if you were to actually look at the original product insert for IOFLUPANE, it did include the SSRIs as interfering medications. And while that's true, the changes associated with SSRI usage is very, very small. And so, again, remember that a patient presents to you, they've likely suffered at least 50% loss, maybe 70 or 80% loss. And research has shown that the impact of SSRIs is on the order of 1 to 3%. So the impact is too small to make a difference to the visual assessment. So fortunately, there's no need to instruct patients to come off of these common medications. So these are drugs that will significantly interfere with IOFLUPANE binding. The first two on the list are the ones that are commonly encountered. The antidepressant Wellbutrin, also sold as Zyban for smoking cessation, can interfere, so one wants to discontinue that if able for 8 days. If the patient is on one of the ADHD or ADD medications such as Ritalin, you'll want the patient to discontinue those for 7 days if possible. Both of these will cause a decrease in uptake on a DATSCAN, so they can potentially give you a false positive study. Much less commonly, you'll encounter patients on the CNS stimulants, and then the recreational drugs or drugs of abuse can have an impact, so you do need to ask patients about them. If you're using quantification or semi-quantification, especially in a research setting, only then would things like the SSRI comes into consideration. Otherwise, you don't want to worry about them. They're not going to cause you to either over or underdiagnose someone on a DATSCAN. So briefly, let's review the role of quantification. Like I mentioned at the beginning, visual analysis or qualitative assessment is fine for the vast majority of cases. But there have been some studies that have shown that will improve diagnostic accuracy. It certainly can help diagnostic confidence, especially if you're not an experienced reader. Also, if it is certainly useful as a research tool, it's being more reproducible than the subjective assessment, and it can also be helpful for measuring severity of disease, as well as potentially measuring response to therapies and things of that nature. The one I'm going to talk about briefly is a semi-quantitative measurement called the specific binding ratio, or SBR. It's probably the one most commonly being used. What it does is it looks for uptake in the strata as compared to the background. The important thing to know is that there's a lot of different software packages available, and they each have unique aspects. So therefore, you need to pay close attention to the one you may be using at your institution and follow their prescribed techniques, because technique is critical. So this is an example of the SBR in a normal patient. You see here what the software does is identify the striatum. It breaks it down into caudate as well as the anterior aspect of the putamen and the posterior aspect of the putamen, and then gives you a background region of interest. You can see here that's using the occipital cortex, which is normal, but some approaches use the cerebellum in place of that. And for this software package, which is the GE DATQuant package, a normal ratio is greater than 2. And so as you can see, this patient has a normal uptake of 2.3 and 2.4. Again, mild asymmetry is okay. This is what are called weak commas, and when present is associated with increased conspicuity of the background. So you apply quantitative assessment. As I mentioned earlier, 2.0 is the cutoff for normal versus abnormal, and this confirms for you that both are abnormal. This atypical abnormal type of DATSCAN is being seen actually with diffuse Lewy body dementia, and it's called balance loss. So while ideally you often see loss in the putamen before the caudate, or it's markedly asymmetric between left and right striata, sometimes all of them can be down. Both the caudate and the putamen on the left and the right can be down, and you get balance loss. This appearance has been reported in about 20 to 30% of cases of Lewy body disease. And in my opinion, it's probably one of the reasons why the exam sensitivity for that specific disorder is a little bit lower than for the other Parkinsonian disorders. The sensitivity for Lewy body dementia is about 78%. Again, it's partially because of this pattern of loss that's difficult to see qualitatively. So if your institution does not have quantification, all is not lost. If you have something like this challenging case, remember you can use I-123 MIBG to look at the heart and its innervation. Certainly if it's abnormal, like it is in this patient, you can feel comfortable that you're dealing with Lewy body dementia in the appropriate clinical setting, presenting with balance loss on their DATSCAN. Other things you need to take care of with quantification is the time from uptake to imaging. You see here in the study of healthy males, they looked at the specific binding ratio at 1 versus 2 versus 3 hours, and it showed the value increases with time. So it's important to wait the recommended full 3 hours before imaging. You also want to try to use that same time delay on future exams so you can have accurate comparisons to prior studies. Here's just another example of why technique is critical. The critical frequency that you use for filtering impacts the quantification. Here we see a critical frequency of 0.3 being employed on the middle image. Compare the differences to that when you use the appropriate critical frequency of 0.6. In addition to the qualitative appearance, it affects the binding ratio. It goes from 1.9, which is slightly below normal, to a normal value of 2.3. So again, the most important thing to know is if you're using any sort of semi-quantitative or quantitative approach, you really want to look closely at the package you are using at your institution and follow their guidelines closely. So in conclusion, DATSCAN has high accuracy for the identification of Parkinsonian disorders. A normal scan supports the diagnosis of things such as essential tremor, drug-induced Parkinsonism, psychogenic disease, and sometimes vascular Parkinsonism. Also, if evaluating a patient with dementia, it supports the diagnosis of Alzheimer's instead of Lewy body dementia. When the scan is abnormal, it indicates the presence of one of the Parkinsonian syndromes. Like I've harped on, the visual assessment really will suffice in most cases. If your facility is performing quantitative assessment, it can help out on challenging cases such as one of balance loss that you can see with diffuse Lewy body dementia. But again, you have to be diligent about technique. If you do not have quantification, you can consider adding MIBG imaging to heart to look for its innervation or lack thereof. That can help tease out between idiopathic Parkinson's disease and some of those less common variants. It can also assist in differentiating between Alzheimer's disease and dementia with Lewy body disease when you have an equivocal case. And finally, careful attention to patient preparation. Their medications, as well as acquisition, patient positioning, and patient motion are important to eliminate some of the common pitfalls that we talked about. I want to thank you all very much for your interest in this topic of nuclear medicine. As one final note, I use the term DATSCAN throughout the talk, but a generic version of the same radiopharmaceutical is now available through Curium as of March 2022. Thank you again.